Good morning, everyone.
Good.
I would like to thank Professor Krzysztof and Professor BISMUTH for the opportunity to present our case. I'm from Coimbra. My name is Ricardo Martins.
Can you speak up? Speak a little louder.
Louder. Okay, thank you. So, after a complex case of a big resection, we bring you a case of decision-making difficult process. So, we are going back to 2012, June, a 60-year-old male with a past of malaria and hepatitis B and C, and some alcohol consumption. In the family history, he had a past in his father of alcohol consumption, and in June, he comes to the ER with complaints of right pleuritic pain and cough with 2 months of evolution, with a normal X-ray and a normal study, cardiac study. On the lab, he had a high gamma GT, and in the abdominal ultrasound that he performed, he had multiple hyperechoic nodules on the left lobe, the largest lesion, and it was some lesion also in the left adrenal gland. So he was admitted to complementary study, and he performed CT. Okay. So he has this huge mass on the left lobe, invading the right lobe, and this huge left adrenal gland also. And in the pulmonary CT, there were multiple bilateral nodes. I will skip on it. I think the CT is clear. So, large mass on the left adrenal gland, large mass in the liver, hypervascular, bilateral pulmonary metastasization. So this was a multifocal hepatocellular carcinoma with metastasization. Alpha-fetoprotein was almost 500. We performed a tumor biopsy to confirmation that confirmed the hepatocellular carcinoma, and the staging was an advanced HCC with metastasis and IVC thrombosis. The patient was proposed, we are into 2012, we proposed the patient for sorafenib. More or less 3 months after the treatment, alpha-fetoprotein rised 6 times or 7. Patient was well adapted to sorafenib. Alcohol consumption was stopped, and he performed a new CT that I will show you. And the thoracic extension of the CT. We had 3 months of therapy with sorafenib here, 3-4 months. So, the comparison between the CTs, you can see that was a great response in the liver, great response in the adrenal gland, and a great response in the thoracic extension. So, no visualization of pulmonary metastasis with exception of 2 pulmonary residual nodules, a reduction in the adrenal mass, IVC thrombus reduction, and an hepatic lesion size reduction from 17 to 6 centimeters. We considered a partial response to treatment. Negative tumor markers in January 2013, stable disease, good tolerance, and here, what to do? We are in 2013. I will move on and then I think we can discuss the case later. So we decided to continue sorafenib on this patient until September of 2018. So we had more than 6 years of treatment with a patient with negative AFP levels, with stable disease on CT findings. He restarted alcoholic consumption in the meantime, and we had only hypertension as an adverse event to sorafenib. In January 2019, so 7 years after the first diagnosis, we had no new pulmonary suspicious lesion. All lesions were stable, but we had a new hypervascular nodule with washout in segment 6, compatible with an HCC. So 7 years of a great response to sorafenib with stable disease and a new nodule in segment 6. And we thought we could have an HCC that was resistant to sorafenib. Here, we studied this nodule with an hepatic MRI with contrast enhancement in February, but the patient had a stroke with full recovery that delayed the MRI that he performed in May 2019. This is the MRI. If you want to, I can pass slowly, but here is the nodule. It is diffusion restriction. And with Primovist, the nodule performed no captation of hepatospecific contrast. And the nodule is here. So this nodule was classified as a LIRADS 4, a probable HCC, and here was our great doubt: what to do in a patient with a 7-year history of good tolerance and good response to sorafenib, which appears with a new nodule in the segment 6. And so, as I said before, we thought this nodule to be resistant to sorafenib, and we performed an adrenal and a partial liver resection. The patient, this is the summary of the patient. We performed a left hepatectomy and a segment 6 resection and a left adrenalectomy with lymphadenectomy. No postoperative complications and 8 days of hospitalization. And in the segment 6, we had a solid HCC with 30% of necrosis, CK19 negative, no microvascular invasion, no tumor, but no tumor evidence on the left hepatic lobe, no tumor evidence on adrenal gland, and no lymph nodes invaded. So 1 year after the surgery, he maintained negative AFP levels, good tolerance to sorafenib that we kept on the patients, and we had a new relapse on the suspicious on the liver there, and 2 masses on right and left adrenal gland, and an hyperdensity, no wash in, no wash out on the segment 6. So we ordered an MRI to the patient, but after the first he performed before the segment 6 resection, he refused to do anything else than sorafenib. So we are in 2021, and probably is right. AFP levels are normal. He performed a CT in July 2021. probably on the liver there is no relapse. Probably has a relapse on both adrenal glands that are stable under sorafenib. And so the patient, we are keeping it on palliative treatment with sorafenib because he refuses any other treatment, including the new drugs for HCC. Thank you.
Any comments? I think we go to the next.
A very particular case. Thank you very much. It's clearly one end of the spectrum of a very strange disease.
Yes, it's out of the box.
And surprising. Yeah. Thank you very
Here,
much.
the difficulty was to decide if we operate the patient with a relapse or no, but the surgeon is always with a trigger that can treat anything that the chemo can do anything.
Yep. Thank you.
Thank you.